Hi, everyone. Welcome. It's such a great pleasure having you all with us. It's a really great pleasure. Good afternoon from Germany, wherever you are in the world. So it's my great pleasure to welcome you to this WEO World Endoscopy Organization webinar on advanced endoscopic imaging for diagnosis of inflammatory bowel disease. I'm Helmut Neumann. And of course, I'm not alone because at all, I have to thank very much the WEO for this opportunity, giving this webinar, but you can already see Professor Despott as well. And we have even Professor Marietta Iacucci, we have Professor Raf Bisschops, and we have Dr. Eugenio Tontini. And I'm so happy that we have these great experts here in inflammatory bowel disease today. And first of all, it's my great pleasure to introduce to you Professor Marietta Iacucci. Marietta, we know each other now for more than 15 years, and we both started in the field of confocal imaging many years ago. Originally, Professor Iacucci is from Italy, but she has seen so many different places in the world. She has worked in London, in Cambridge, in Germany, of course, in Italy. She was in Tokyo many years, in Calgary, in Canada, and now she is a professor of gastroenterology at the University of Birmingham. So Marietta, it's a great pleasure having you here. You are one of the biggest stars in inflammatory bowel disease imaging. You have done tremendous work in different fields of IBD, and at least you're also part of the task force of the European Crohn's and Colitis Organization of the ECHO. So it's a great pleasure having you with us. Thank you so much for your time, for being with us. Also, my greatest pleasure to introduce a very good friend of mine. You're all good friends of mine, but yeah, Raf, you know that you're my very close friend. And Professor Bisschops is director of endoscopy at the University Hospital of Leuven since many, many years, but he's also Secretary General, sir. Yeah, because you are the Secretary General of the European Society of Gastrointestinal Endoscopy of the ESGE. Definitely he will become our president very soon as well. I have no doubts on this. And also he is chairing a lot of committees of the ESGE and doing a fantastic job in multiple publications, at least on endoscopic imaging techniques, on inflammatory bowel disease, on colorectal lesions, and on Barrett's esophagus, of course, as well. Yeah, so Professor Despott, so you look like you are at holidays, but we all know you are heavily working and you have a fantastic working day today, of course. And Professor Despott is really Professor of Medicine at the Royal Free Hospital in London. He's providing one of the most magnificent conferences every year, the AM Masterclass in London. So thank you so much for taking the time for being with us. You are the experts when it comes to advanced resection, when it comes to thinking outside the box, like transnasal endoscopy. But of course, the first step always is detection. And therefore, we are very happy that you're giving today the first talk on detection. So very keen to learn a lot from you today. Yeah, and at least I'm so happy to introduce also one of my very closest friends, and this is Eugenio Tontini. Dr. Tontini was one of my fellows many, many years ago. He was the best fellow I've ever had in my endoscopy career. And now I'm so happy that he is now senior, of course, as well. And he has done more than 100 publications already. He's the experts now when it comes to small bowel imaging, small bowel endoscopy. And I'm so happy that you are today with us. And we see that you are still in the hospital. So thank you so much for taking the time in your very busy schedule for us. So ladies and gentlemen, dear friends, again, it's such a great pleasure. I'm Helmut Neumann. I'm the head of the WEO working group on inflammatory bowel disease, that you're taking your time this evening, morning, afternoon, wherever you are in the world, to join us for this fantastic symposium. I think we want to cover everything today. We want to discuss about detection. We want to talk characterization, we want to talk about mucosal healing, and we want to talk about small bowel endoscopy and IBD, of course, as well. And therefore, I will open the floor to Professor Edward Despott from London to give the first talk, and if you allow, about advanced endoscopic imaging for dysplasia detection. Thank you so much, and please enjoy.
I will try to share my slides. So Helmut, thank you so much for that extremely kind introduction as always. a great honor and a pleasure not only to be with you, friends, but also to be presenting on behalf of the World Endoscopy Organization and its very honorable and noble mission. I hope you can see my slides, Helmut. Are they working well?
Perfect. Thank you very much.
So these are my disclosures, and today we'll be talking about detection of dysplasia. I'll give you a bit of an overview of my talk. We'll talk about the background, the imperative basics for a detection of lesions, not just dysplasia. We'll talk a bit about the imaging, the guidelines, the evidence, and of course, management, and then we'll summarize. So a bit about the background. So it's different, okay? This is driven by chronic inflammation. The dysplasia we see in colitis is different to the usual dysplasia we get in sporadic cases, which brings us to the most important thing that our dear friend Marietta will be talking about, mucosal healing, and why it is so important to detect it adequately and also to control disease. Because if you have chronic inflammation, you drive those mutations, you're going to get that field change, which is why you have a risk of multifocal, synchronous, and metachronous lesions in these patients. And this is why, even when we do find some dysplasia, we really have to keep a very, very close watch. The driver is inflammation and control that disease. We know, of course, that the anatomical disease extend, the more disease there is, the more risk there is associated with it. It also goes to show that if you have disease at a young age, you are also going to get greater exposure. For some reason, male gender, like many things in life, and also a family history of colorectal cancer, because you've already got some mutations there. And it's peculiar to this illness, PSC, primary sclerosing cholangitis, which increases the risk on its own fourfold. There is some good news, however. The incidence and mortality from this type of disease is declining, whether it's relating to better disease control, surveillance, or both. We hope both, really. So switching gear to the imperative basics, not only for dysplasia detection, but this holds, of course, for any lesion detection. So in this disease particularly, we have to go for it in remission, the best disease control possible. And of course, with excellent bowel preparation. It goes to show that go for your best bowel preparation score and clean those out. And this was lent to me by my good friend, Professor Eugenio from Gichi Medical University, which we have a very close relationship. And the Japanese prepare the colon in conjunction with the patient. They empower the patient to actually only come to the colonoscopy when they have a bowel preparation that's actually perfect, okay? So wash. We are very lucky to have scopes that have a dedicated water jet channel, so it's no excuse nowadays not to use it. You can get these from any company. All companies make them and utilize them. Don't leave that patch of mucus, because beneath that patch of mucus, especially on the right-hand side, you might be hiding a dysplastic lesion. And change position. This is no news. Brian and colleagues had shown this a while back, along with James East, that if you change patient position, you expose more mucosa. If you expose more mucosa, the greater the chance of seeing lesions. And of course, the usual basics like cecal intubation rate, get the best quality endoscopist that you can be, improve that adenoma detection rate, and of course, slow down your withdrawal time. Shifting gear again to imaging. So imaging, if you take one message from this lecture, it's high definition, HD. All the literature points to HD, whether you're using it with color, without color, with electronic chromo, or without, high definition is key. So whether you use white light or not, high definition is key. And of course, what is the definition of high definition? Like any optical instrument, it's all about resolution. If it's a microscope, if it's a telescope, if it's an endoscope, if you've got a high definition instrument, it's able to resolve two particulates, which if using a low definition instrument would be seen as one. So the ability to separate those two things out increases the ability to define lesions, and of course increases your ability to detect them. Going on to catheter-based or dye spray-based, the basics on how to do it. Of course, you withdraw the catheter while spraying. You spray again in areas which haven't been sprayed, and then you oppose the mucosa by sucking out, and then you go and inspect. Of course, it's useful. Of course, it's been the mainstay of care, especially when high definition did not exist, but it's messy, and you can end up looking like a famous colleague of ours. So, before the advent of high definition, chromoendoscopy is king, and I'll show you why this is not the mantra anymore, especially because of the fact that it's messy and time consuming and we can't do without it. So all data before supported higher lesion detection. So it allows us to drop quadrantic biopsies, which were the mainstay of care a long time ago. That was akin to taking some pieces of grass out of a football pitch and hoping that you pick up the grass that was diseased. Funny, very low pickup. Of course, it was reflected in the guidelines, so everyone was advocating the use of chromoendoscopy, and until very recently, that was still the case, really. In parallel to this, in the background, as you know, Olympus was first on the block with this narrowband imaging, the actual electronic blue light, okay, that allowed us to get the contrast that we needed by using hemoglobin in vessels which were already there. So by switching to blue light, we detected greater contrast and higher definition became even better. When we moved in that direction, of course, other companies came on board. Fujifilm came with blue light or blue laser light imaging. iScan was produced by Pentax as a post-processing alternative. FICE was being phased out by Fujifilm as its post-processing alternative. And then we started seeing new things come along, which may hold even more promise in the future. Things like linked color imaging, which uses a magenta type light and may be useful also for detection, not just characterization. And of course, as happens, the other companies start taking root, and the TXI came in looking at texture and also color, which also includes post-processing. So it's going to be an exciting time, but not for the color blue as in the bottle. We are moving away from actual dyes, moving on to chromo, and I'll show you why it's electronic chromo rather than anything else. But the guidelines until recently, even when we looked at the scenic convention, which was the main driver, putting some sense into all this disarray, also advocated the use of chromo. But gradually, some evidence is now displacing that. Scenic, I must say, was endorsed by the American societies, the British societies, the Canadian societies, and even the Japanese. So the critical thing here was also the relationship with HD. Use high definition. The bottom line is use high definition. Electronic chromo was not yet recommended, but they also advocated the use of chromo. ECHO guidelines, use high definition. Electronic chromo, not yet recommended. ACG 2018, use HD, use high definition. Plus or minus chromo, there was room for that, but electronic chromo was not yet recommended. And then Raf came along and the working group, and with that famous paper, they changed things. So use HD white light, drop quadrantic biopsies, one of the first to say just drop them, and then electronic chromo was becoming to be endorsed. And why? Again, this is a very critical, important paper from Raf's group, well-designed, adequately powered, multi-center, and prospective, what you really need, and randomized, of course. And it showed that there was no difference in the detection rate between chromo and electronic chromo, and electronic chromo, of course, was 7 minutes faster and probably much cleaner and less messier. And the reasons why chromo endoscopy with dye spray had been entrenched for such a long time was that it was the only thing that allowed us to detect a color difference, a bit of contrast, highlighting also those ridges with the contrast sitting in there. But with the improvement in electronic chromo, it becoming brighter, remember that even NBI is now just as bright or even brighter than the previous HD white light, things are becoming much clearer and the contrast improves even further. And this is important, especially in colitis, we're not usually looking at the polypoid or semi-pedunculated lesion. We're looking for flat things, and we're looking for red things, has been shown by this paper from Tokyo in Japan, looking at 40-odd particular cases of low-grade and high-grade dysplasia, bringing forward that these are usually flat lesions and they're usually red. Hence why electronic chromo works really well for these and the detection. I love this paper by Marietta's group. It really looked at the post-scenic and post-Dalm era by looking at these particular lesions. And they looked at specimens which were treated post-surgically in patients who had developed cancer in this context. And again, highlights the important difference between the dysplasia we get in standard colonoscopy detected, like the adenoma pathway or the serrated pathway, saying and showing that these are more similar to the serrated things, but are also different. And there's always going to be that inflammatory component, that inflammatory driver. Hence why we have to look for those red patches and look differently. And this is an area of low-grade dysplasia which I detected at one of our screening colons. You can see that subtlety there, that subtlety, and you're not going to get the changes that you get in standard ways. And this is a slightly more obvious one, the one on the right. It's also not just got that flatness and redness, but it's also got the scribriform 3D component, which is almost villous and is highlighted more by bright NBI and near focus. Okay, so yes, we can find them if we know where to look. So when do we consider endoscopic management? This is from the ASG guidelines and from the scenic guidelines, but it's mirrored effectively by our ESG guidelines. And it is obvious, if you don't have a lot of field change, if you have solitary lesions that you think you can remove them, but keep them under very, very close watch. Remember the field change. And when not to consider endoscopic management, when there is indistinct diffuse dysplasia, features suggestive of deep submucosal invasion, and have a lower threshold to go gung-ho for younger patients, because these are more at risk. Always back your decisions up by a multidisciplinary team meeting. Have every clinician that can help, include your histopathologist, have consensus, and always take into mind the patient's, which is age and comorbidities. There are challenges to endoscopic resection. Helmut, Raf, and colleagues, of course, these are going to be inflamed. They have distorted margin. They are going to be tethered down by fibrosis. And the ways to overcome these challenges many times are to employ the use of ESD. And in our case, we use saline immersion. So this was a lesion in a long-standing choletic who was quite young and did not want an operation. So after assessment and confirming that this was just low-grade dysplastic, we employed the use of saline immersion therapeutic endoscopy facilitated pocket creation method, ESD, and you can see that there is fat in the submucosal space, meaning previous healing from inflammation, and so on and so forth. I'll speed through this video in the interest of time, and you can see that the lesion was out. You can see the fibrosis there, difficult ESD, but with success and an R0 resection. And the evidence is coming out by Japanese colleagues showing that this is a very useful tool. Other consideration, don't forget the tattoo, mark those lesions, keep these under extremely close surveillance. And of course, don't forget that you can use other things such as full thickness. What's the future? I think the future will have a combination of LCI and TXI, these new technologies that help us detect, but of course, artificial intelligence. So take home messages, Raf and Helmut and Marietta and Gian, adequate bowel preparation and cleansing in remission, use HD and use HD, high definition instruments, chromo or e-chromo. E-chromo is just as good nowadays, there's the evidence, and have the right management strategy for your patients with multidisciplinary team involvement. I would like to thank my team. I would like to invite you to come to Endo 22 in Kyoto, and of course to the AM in 2022. Thank you.
Thank you so much for this most powerful lecture. It was a fantastic lecture, so extremely exciting to learn from you. Also, thank you so much for sharing your fantastic video at the end, really highlighting your massive skills on endoscopic resection, highly fibrotic lesion, but it's looked so easy, no bleeding at least, we have taken it out. Congratulations, thank you so much. So you have already shown us the future. In your experience, it's electronic chromoendoscopy. So you said dye-based chromoendoscopy is something of the past. So let's go the next step. Do you even think besides electronic chromoendoscopy, we'll see maybe new things like tablets with chromoendoscopy, with methylene blue maybe, or maybe even artificial intelligence in the near future, what will help us detecting more lesions in inflammatory bowel disease?
I think, thank you, Helmut, and thank you for your very kind comments. AI is the future. Artificial intelligence is going to be the future. MMX capsules, you've seen it in screening. I'm not sure whether it's as useful in colitis. We still need to study that. But if you can avoid dyes, why put in dyes? Artificial intelligence, probably with assistance of LCI, TXI, possibly NBI, that's the future. A little guardian angel sitting on your shoulder telling you, that's the lesion, Despott, go for it.
Thank you so much. And we have also one question from the audience. And again, we want to encourage you. So you're all here with us. So we want to do it really in a cooperative way. When you have any questions, please feel free to use the chat functions in the lower part of the Zoom conference. Just enter everything. And Raf already entered something, but we just want to ask. So maybe Raf, you can come live as well, because you have already answered this question. So the question was, what about the withdrawal time in IBD screening colonoscopy? And you have already mentioned your study. So I wanted to bring the question to Ed, but now you have answered it already. So you have done a study. What's the answer to this?
Yeah, it's usually longer than a standard colonoscopy. You really need to look for those little lesions that Ed nicely showed. And for that, you just need more time. So on average in the study that Ed showed, we had more than 20-minute withdrawal time. So that included everything, the biopsy taking, and for the dye-based chromoendoscopy, also the chromoendoscopy itself. So my usual advice is to at least schedule a 45-minute slot if you're familiar with the technique. And maybe in the beginning, because you have to learn these techniques, so you may even schedule 60 minutes, so you become more faster and more acquainted with the features of these sometimes subtle lesions. You show some very nice examples there to illustrate how difficult it can be to detect these.
Thank you. Yeah, and you're also chair of the ESGE quality committee. So I feel this is most valuable now for all of us to learn from you what we really need to spend. And Ed, finally, if you allow the question, so once we have detected the lesion, once we have resected the lesion maybe as well, would you recommend always to take some biopsies from the surrounding mucosa as well in order to rule out neoplasia, at least from these traditionally what we consider to call DALM lesions, or is it not necessary? Should we only do these biopsies when there is chronically inflamed mucosa, or would you say in general it's not necessary?
Yeah, I think I would. That's a very good question. I would take some background biopsies regardless, because the margins are very indistinct. That's the problem. You saw that ESD that I did, the margins are indistinct. So that's the biggest problem we have. That's why anything that helps you, like Zoom and the Z-chromo and even the TXI and LCI, they can help you demarcate, and switching on NBI or BLI can help you demarcate. But sometimes it can be tricky. So yes, having some background is okay. And I'm sure that Marietta will show us how to detect proper healing, because it's all about the driver of inflammation, as you heard, and inflammation drives this.
Thank you. And yeah, so you already mentioned Zoom is helping us, and Zoom is not only helping us for endoscopy, but also to communicate with the world, because again, WEO is the world of endoscopy and the voice of endoscopy, and therefore we are so happy that the WEO is giving us this opportunity. And I also want to invite you to join the WEO website, which is really covering a lot of aspects regarding the different topics of endoscopy. Also, you are highly invited to become a member of the Society in order to receive regular updates and also to visit the YouTube channel if you like, because there is a constant educational series on endoscopy. So thank you so much. And I'm looking forward to Professor Iacucci, Marietta. So we have already learned so much now from Professor Despott on advanced imaging for dysplasia detection, but the question is not only to detect dysplasia in inflammatory bowel disease, but also to manage subsequent pharmaceutical therapies. And especially from you and your fantastic group over the past years, we have learned so much about the importance of mucosal healing. So we are so keen and so thankful to learn now from you about the assessment of mucosal healing with latest imaging techniques. And thank you so much, Marietta, again, for being with us. And we're so much looking forward to your talk.
Thank you, Helmut, and thank you for the World Organization, Endoscopy Organization, for inviting me. So let's see together if advanced imaging are useful to assess mucosal healing in inflammatory bowel disease. So these are my disclosures. And what are the hot topics in 2021, regardless the mucosal healing in ulcerative colitis or in IBD? So definitely mucosal healing, or now we namely endoscopic remission, is an important hot topic to achieve. But does it really exist, and how deep we need to go? And does it really help using optical diagnosis or the new advanced technology to assess and monitor inflammation in mucosal healing in ulcerative colitis or Crohn disease? But, and most important is we talk about endoscopic target to treat. And definitely the advanced technology are important to tailoring therapy, especially in the new, we have so many drugs, and we should tailor which one is the best for our patients. And finally, because, you know, as the artificial intelligence is our future, do we need artificial intelligence to assess better mucosal healing in inflammatory bowel disease? So we know very well, then stride to recommendation for treatment to target is in IBD is endoscopic remission is a long-term target. It's because it's the favorable long-term outcome for these patients. However, recently we are talking about histological remission, despite the fact that the histological remission is not considered the formal target yet, especially in Crohn disease, because we talk about transmural healing. And indeed, in this talk, I'm not talking about Crohn disease, because Crohn disease assessment requires not just endoscopy, but also cross-sectional imaging. But so look at how we changed the concept in the, you know, from the past. For us, it was important to target the clinical remission. Now for stride 2, we need to consider endoscopic remission. But recently, we're talking about more rigorous endpoint, which is endoscopic remission, histological remission, because we want deep healing. But why this is important? It's important because endoscopic remission has a favorable outcome and prevent also cancer in dysplasia and inflammatory bowel disease in terms of hospitalization, in terms of colectomy, in terms of steroids-free. And if you see also histology normalization is associated with less flare-up of the disease in long term. However, another point which we need to take into account, some country and indeed ECHO come out with this topical review about the exit strategy. So we need to consider at some point after 1 year of treatment with biological therapy, if we need to exit. And so at this point, the endoscopic assessment of the endoscopic healing, it's crucial to escalate or de-escalate treatment to have a favorable outcome of the disease. And you can see what are the endoscopic score then we use? The first, we know in ulcerative colitis, we use the Mayo endoscopic score. It's the common in clinical practice. People love it. It's easy. Or recently, we have also the USIS, which goes into details more the vascular pattern, bleeding, erosion, and ulcers. However, these endoscopic scores, they have some limitation. And we talk about mucosal healing, we talk about endoscopic remission, or even histological remission, but we don't have yet with the Mayo score and with endoscopic USIS, the definition of endoscopic, of mucosal healing or endoscopic remission. And Mayo is not validated yet as endoscopic score, and USIS doesn't have a threshold of mild, moderate, and severe of disease, and not definition of mucosal healing. But most important is then there is a discrepancies between endoscopy and histology. We need to consider that in endoscopy, this discrepancy is the 40%. And indeed, recently, the new clinical trial, they are considering the endoscopic combined rigorous endpoint, which is endoscopic remission, histological remission. But this really is not true, because these discrepancies just is related with the use of the previous generation of the scope, which are the white light standard endoscopy. And indeed, if you look at how recent development of the Picasso score, which is the first virtual chromendoscopy score, we have showed that endoscopy is getting closer to histology. So from the past to the future, the new technology can correlate strongly with histological remission. And for the first time, we have introduced the concept of the endoscopic definition of the mucosal healing. This is the Picasso score. So you can see we have looked at the mucosal architecture and the vascular architecture. And so for the first time, we have a definition of mucosal healing. You can see clearly that when you have virtual optical diagnosis, you have more definition of the mucosal pattern and the vascular pattern, and you can distinguish very well, especially when you have patchy inflammation, so between healing and between mild inflammation, which is the most important things to assess, especially when you need to choose for your choice of treatment, or when you need to for your outcome in terms of disease flare up. So let me give you an example. It's very easy. All of us in endoscopy unit has the optical diagnosis, and it's just switching in a real time the button on the end piece of the scope. And you can see in this video, it's clearly then with high definition, despite its bright high definition, you couldn't see what you are seeing now with the virtual chromendoscopy, which is the micro erosion. You couldn't see just this patch inflammation, so you don't target the biopsies. Of course, you don't see this mild inflammation. You change your treatment, maybe de-escalate, and then at the end, the patients will have a follow-up in 6 months' time. And also with the virtual chromendoscopy, you can target perfectly, accurately your biopsies. So these are Picasso's study. We have enrolled 370 patients, which is a large cohort of patients, 11 international centers. We have used first white light, and we have assessed MES and USIS. And then we have, with virtual chromendoscopy, we have assessed Picasso. And then we look at Picasso mucosal, Picasso vascular. We have targeted the biopsies, and you can see the correlation between endoscopic and 5 histological scores was strong. And the Picasso with a cutoff of less equal 3 could predict long-term outcome. So there is no discrepancies. The endoscopic endoscopy is getting close to histology when we use the advanced technology. And the same, if you see with the LCI, you can see the LCI, they have developed a score, which is look at the redness of the vascular pattern and LSY1, A, B, and C. And they have showed that also with another platform, the LCI may be a novel approach to evaluating perfectly, accurately the grade of inflammation and predict the outcome in UC patients. And indeed, I can also anticipate, then the paper has been submitted, then we have showed that the Picasso score can be reproduced easily with NBI and also with BL Light. And this also is another, our paper where we have looked at the same patients through the optical diagnosis and the confocal endomicroscopy, which we look at briefly about the confocal, is just a dynamic, assessment of the histological, in real life histological healing. And then you can see, we can. So then the endoscopy can look at, reflect histological healing in ulcerative colitis. But let's moving forward. Let's see, the endoscopy is, the armamentarium is just, we have a new technology, and you can see this is the endocytoscope, is the new scope, which you can see in real-time histology. It's a magnification, so you can see with virtual chromendoscopy, you can magnify, you can see the erosion, you can see the inflammation, but you can see healing. So how do you perform this? You use a mucolytic, which is the acetylcysteine, and then you can see the Meckelin blood 0.1%, and then you can magnify, and you can see by attaching the scope onto the mucosa, and you can see the distorted crypts, you can see the infiltration of the cell, you can see really the histology in real time. And based on this, we have a note. You can also see with endocytoscope the ileum, and you can see here these are the same patients. You can assess the barrier function and see, the epithelium and predict. Eventually, in the future, there is no study yet about predicting a flare-up of the disease after treatment. This is what we have developed. We have developed a scoring system where, based on crypt architecture, infiltration of cell, distance between the crypts, and visibility of superficial microvessel, which was similar to the Japanese, was just adapted. And you can see the endocytoscope can predict healing by NHI and RHI. Then they are the new validated histological score used in the observational study and the clinical trial with a very good accuracy. But what is the future? The future is definitely artificial intelligence. And you can see with the artificial intelligence, so with the endocytoscope, Marietta has developed this cut of the endocytoscope, which can predict accurately almost 100% histological healing. So this is what is the future, what we'll have in our endoscopy unit. You can have, definitely you assess first the eye definition, then you can assess with optical diagnosis, and then you just attach without any dye, and you can see if the patient is healing or not healing. Look at this patient which has patch inflammation, and which has microerosion, and then the artificial intelligence can predict and tell you when this patient has inflammation. And so you will decide based on this what is the treatment or the long-term outcome of these patients. And Raf, and as with this new has developed these new toys, this new toy using this new scope, the single wavelength endoscopy, and you can see it's unbelievable. So you can use high definition, and then you can use this, let's say, virtual, and then you can magnify, and then you can see the crypts, the pericryptal capillaries, the crypt wall and the collecting venule, and you can target biopsies, but also in the future, this kind of, endoscope and artificial intelligence can tell you if the patient is in healing or not. And to conclude, I want to just say this, it's also important, the endoscopy molecular. So, and this is our study who has been presented, and you can see now, you can also, it's just that with the new advanced technology, you can also predict tailoring therapy. So this is our cohort of patients. The patients then have been treated before initiating biological therapy. We use the advanced technology, optical diagnosis, and confocal endomicroscopy with molecular labeling in ex vivo. And then, of course, we did also other omics. But you can see we have developed a computerized image analysis ex vivo in vivo for confocal endomicroscopy, which is a dynamic, assessment of the histology. And you can see we couldn't predict response to therapy, but also assess mucosal healing. And in the future, probably this is a new field. Then with the fluorescent labeled biological agent, we can predict in advance tailoring our therapy. And so in conclusion, what are the message to bring home? You have optical diagnosis, and we have all of us virtual endoscopy. Please, when you assess the patients with IBD, it's important, switch the button, look at characterize the mucosal vascular, target your biopsies. It's crucial for the treatment. And it's important to this characterization is endoscopic features. Detailed endoscopic feature will help us to develop a better artificial intelligence for the future. New armamentarium is endocytoscope also can help, of course. It's especially built in the artificial intelligence, and in the future, the advanced endoscopy technique can help to tailoring and personalize in therapy in IBD. Thank you.
Marietta, thank you so much. What a fantastic, excellent lecture. And we have learned so much from you. Congratulations again to Picasso. So Picasso is Paddington International Virtual Chromoscopy score. And Paddington is not only a bear, but Paddington is also a part of a district of London. So there was the original development of this. And Edward, you're saying yes, because you're also from London. So you know Paddington. Next time at the AM, maybe you can do a great evening dinner for all of your participants in Paddington as well with a bear. No. But Marietta, thank you so much. Congratulations. And we have learned from Ed that for detection, target biopsy is very important. But now we are learning also from you that also for assessment of mucosal healing, also assessment of targeted biopsies seems to become really important. Would you also to recommend that we are taking corresponding pictures from every segment as well? So picture, endoscopic picture and biopsy as well, or would you say this is not necessary at all?
I think if I just looking at the new quality indicators, key quality indicators that we are just developing with European Society of Gastrointestinal Endoscopy, definitely I think it's important to document the photo documentation. At least I know that the clinicians are very busy. Maybe they don't want to take picture for each segment, but at least the most representative area of mucosal healing or activity of the disease.
Thank you so much. And for some of the participants, maybe even to highlight again, so even though we have macroscopically non-inflamed mucosa, because you have highlighted the advantages of advanced imaging modalities, including endocytoscopy or other technologies, but even in the case of macroscopically non-inflamed mucosa, one should go a little bit more into detail, take your time and take not only random biopsies, but one should take targeted biopsies to assess the healing, the microscopic healing, because this is of paramount importance for subsequent therapy of the patient and also for the occurrence of the relapse of the patient. Is this correct?
Here, it's a really good question because we have two different opinions. So if we look at the new guidelines of European Society of Gastrointestinal Endoscopy, we don't recommend to take biopsies in the, in the mucosa healing. Of course, in the well-diagnosed in the diagnosis of IBD. We think in the optical diagnosis, it's a good, can help. But if we look at the ECHO guidelines, they still recommended to take biopsies also in the healing of patients, because I think not all people, they have advanced or experience or advanced technology. So I think the biopsies can help, to direct in monitoring the patients and direct therapy. Depend. I think this is question. I think will remain open.
Thank you so much. Thank you so much, and me as well. And thank you so much. And again, congratulations to the fantastic work. And Secretary General, sir. So we are very much looking forward, Professor Bisschops, because this is really a great honor. And I'm so happy that, Raf, you're also taking the time for us because you have such a busy schedule. You're also president of the Belgian Society of Endoscopy. So for taking the time for us, because we're so much looking forward to learn from you, not only about the detection, because this is what we have learned from Professor Despott. We have now learned about mucosal healing and the importance from Professor Iacucci. But now what about advanced imaging for dysplasia characterization? There is no one who could do this talk better than you, because you have done the landmark papers in this specific topic as well. So Raf, thank you so much again for taking the time, and we're very much looking forward to your talk. Thank you.
Thank you very much, Helmut, for your kind introduction. So these are my potential disclosures. And thank you for giving me this subject. So it nicely adds on to what Edward has been saying in his first talk. However, when we talk about characterization of visible lesions during colitis surveillance, we have to admit that this is very difficult. And in addition, there's not so much evidence available in terms of efficacy and how good we are at it. It's quite a disappointing endeavor, to be honest. So what I will try to do during this talk is to make this a little bit practical. Basically, how we can integrate characterization with the detection that Ed already very nicely addressed in his first talk. So again, we have to go back to the basics. We need to communicate in the same way and use the correct terminology and try to classify the lesions that we see. And this goes back to the old-fashioned Paris classification that is integrated in the SINE consensus terminology that was introduced 6 years ago. So we have polypoid neoplasms that can be sessile or pedunculated, as you can see here, a sessile lesion, and if there's a stalk, it's pedunculated. And then we have the non-polypoid neoplasms that can be slightly elevated, so it's the Paris classification 2A, or they can be slightly depressed, like here, it's a 2C, or completely flat when it's 2B. And maybe before the era of high definition, or if you're not entirely sure, you're still doing random biopsies, you can also have the invisible unrecognized neoplasia. But I find this, if you really look very closely, quite rare to find this. Another thing that we need to address about characterization is the classical Kudo split pattern classification. However, we need to realize that this was developed for classical polyps and adenomas. And obviously, in the presence of inflammation and regenerative tissue, we cannot just translate this and transpose this onto the findings that we find during colitis surveillance. However, what we could do is look at the reassuring findings, and they're not so difficult to identify. So if you look at these round pits or star-shaped pits that we found in normal colonic mucosa or hyperplastic polyps and adenoma, if we try to keep that in mind and differentiate this from anything else that we can regard as neoplastic until proven otherwise on biopsy, this is the way forward to do this. So let's put this in practice. So if we have here the Paris classification or the SINE terminology, this is a polypoid pedunculated lesion. It's a type 1P. And clearly, if you look into detail, you can see these round pits which are identical to the mucosa next to it. So this is a type 1 pit pattern. So this is a classical pseudopolyp, which we don't have to biopsy. In contrast here, we have this sessile lesion. We already know from Marietta's study that this is more likely to harbor neoplasia. And on top of that, there is also a type 3L pit pattern. So this is clearly distinguishable from what you saw before. And even with older endoscopes, so I'm addressing this because this is a WEO session, and not everybody has the advantage of having these high-end, fancy, high-definition endoscopes of the latest generation. But this is a high-definition endoscope from the first generation. Even with Crohn endoscopy, if you move closer, you can nicely identify here this 3L pit pattern that allows you to take a targeted biopsy here to this aberrant pit pattern. So we do this on the spot. You identify in overview a lesion, and then immediately you switch to the characterization mode. And this actually resembles quite nicely a sporadic adenoma in colitis. It's non-polypoid, slightly elevated, type 2A. And again, you identify the 3L pit pattern, or even the NICE2 if you want, according to the NICE classification. Again, an example how it works. So this is white light overview. It's a first generation high definition endoscope, just to show you that it works. You can see an elevation here, but then if you switch on the virtual chromodoscopy, you can better delineate this lesion. And by moving closer for characterization, you can identify this type 4 3L pit pattern, which is indicative of potential neoplastic changes, but you need to confirm this. Why do you need to confirm this? Well, if we apply the approach that I just demonstrated to you, and you use the absence of pit pattern 1 or 2, even an expert hands in this inter-observer study that we conducted after our randomized controlled trial, you can see that it's not perfect. I mean, we do have a pretty good sensitivity, especially if we use chromendoscopy, and in combination with the endoscopic appearance to predict whether there's neoplasia or not. But the positive predictive value of our biopsies and our findings is not very high. Right? It's basically almost flipping a coin. So that's why we need to confirm this on biopsy before engaging into large resections of potential regenerative tissue. The inter-observer agreement is even better for narrowband imaging in comparison to chromodoscopy. So we can try to apply this approach. So it's an integrated detection and characterization mode. Marietta nicely developed the facile classification, although it resembles to be facile, it's really, in fact, not so easy to do this in real life. Anyway, this was a consensus meeting where 60 high-quality images were selected, and the majority of these lesions were actually neoplastic. So it's a benchtop exercise where the expert looked for the features and defined the features and then validated this in a subsequent process to look for inter-observer agreement and to find the features that are associated with different features like the sessile serrated polyps, inflammatory pseudopolyps, dysplasia, or even cancer. So again, it's an integration of the morphology, the scenic terminology, polypoid or non-polypoid, looking at the surface architecture, whether it's roundish, villous, irregular or regular, and then the vessel architecture, whether you can identify regular or irregular vessels. And then also the presence of inflammation, especially if it's absent, it resembles more sessile serrated lesions. So, and how good does it work? Well, these were features associated with a high odds ratio for neoplasia, whether it's non-polypoid lesions with irregular vessel architecture or surface pit pattern and signs of inflammation. The resectability and demarcation in this exercise did not contribute to the prediction of neoplasia. The diagnostic performance of the overall multivariate analysis had a very good sensitivity, but keep in mind, we have to be honest, Marietta, there was a higher prevalence of neoplastic lesions, and therefore the specificity was quite low. So even knowing that there is more neoplasia, we still have to rule out by biopsy whether there is neoplasia or not before engaging into large resections that Ed nicely demonstrated in his video with the ESD. And this is actually in real life also the case. If we do the studies, the neoplasia detection rate in targeted biopsies is around 20% maximum. And this is important for the management of visible lesions. In our study, our neoplasia detection rate per lesion was lower than 20%, 16 to 18%. So therefore, we should not resect every lesion with a neoplastic pit pattern as such. So how do we integrate this now, the characterization during detection for the management of the findings during surveillance? First, start with the easy part, so everybody should recognize this and don't lose any time biopsying these typical pseudopolyps, leave inside and further surveillance. However, we can apply these techniques also for more difficult situations. For instance, strictures during in Crohn's disease or ulcerative colitis. If you look at here, you can identify the general round pit. So it's mostly type 1 pit pattern. So spend a little bit more time looking at what you actually find, and then maybe take one biopsy or something that may be targeted to the most suspicious area. So you do detection and characterization that is integrated. And maybe if you want a biopsy, do it here where you see a little bit aberrant pit pattern maybe. And this was actually all normal. So it is feasible to do this. Here again, you detect something and then you switch in your mind to the characterization mode. You see this fibrin cap, which is indicative of an inflammatory pseudopolyp, and see that the surface pit pattern is regular according to the facile classification. But then when we turn the scope, it actually reveals a totally different lesion that is flat, so it's sessile. It's a non-pedunculated lesion, so it's a higher chance of having neoplasia. And if we move closer, again, you can see the demarcation of the lesion, so we can identify the borders here, and we can identify also the neoplastic pit pattern. So we take a biopsy and confirmed here low-grade dysplasia. It can be very challenging to do this. So we can have many features. So we have to look for lesions, for elevated parts, and then do the integrated characterization. So again, inspect these strictures, and then you have this forest of pseudopolyps. How do we deal with that? Yeah, you have to scrutinize them and go over them. And again, if you spot something, it's really a pattern recognition. You see this is a different pit pattern from all of those type 1s. And if it's so small and in a forest of pseudopolyps, I would suggest to resect it immediately. You can even do a cold snare of this adenoma that was resected. And then you have these lesions, they're very small, so lift them and take them out. And if you want, like Ed said, you can take biopsies surrounding the lesion to exclude residual dysplasia. So if we sum this up, small lesions that may be hard to relocate, resect them immediately. But what about these larger lesions? Again, the type 3L pattern, we need to distinguish this from a regenerative tissue, because as I said before, only 20% of them harvest actually neoplasia. Even for these, you want to make sure that you're looking at dysplasia in this non-polypoid flat type 2A lesion with 3L pit pattern. And if it's confirmed, then you can proceed with the scheme that Ed presented to you to consider in a multidisciplinary approach, whether you do surgery or endoscopic resection attempt. Can be very difficult sometimes to delineate, as Ed indicated. So maybe it's here, and if you're in doubt, make sure you take biopsies in the suspicious part and surrounding part, because here there was dysplasia in both areas. So this is colitis-associated neoplasia with low grade. So if the lesion is larger, you need to biopsy it and then consider elective resection or surgery depending on different factors of the lesion, especially if you have features of deep submucosal evasion like obvious deep ulcerations. We didn't talk about the training yet. We recently published the training, and this is again a combination of detection and characterization. Why is this? Because we gradually go from 20 cases dye sprays with backup of random biopsies, and during that you look at the lesions and you do get histopathological feedback. So you need to go over these 80 cases with targeted biopsies and backup of 4-quadrant Ryan biopsies in the beginning. Then you move to targeted dye spray biopsies alone. Then you move to virtual with the backup of 4-quadrant biopsies. And then you can end up with a virtual endoscopy if it is at your disposal. Then you can use it and switch to targeted biopsy. So this is a training that we refer to in the ESG guideline that was published last year. And you can easily do this. Just go visit somebody for 1 week and learn about the techniques and see some cases. And then you basically have to start your own and track what you're doing. So in conclusion, Helmut, lesion detection and colitis surveillance is already challenging. Ed showed that to you, but lesion characterization and colitis surveillance represents the pinnacle of challenges in optical diagnosis. So learn the basics and use the correct terminology and apply this advanced imaging for detection and characterization. So use the pit patterns to dichotomously approach visible lesions. Resect small lesions on the spot because they may be hard to find, or if they are clearly neoplastic, like if they resemble classical adenomas. But however, refrain from resecting large lesions on the spot because you may opt resecting a lot of regenerative tissue. So you need to confirm this by biopsy before resection. And finally, train yourself with histopathology feedback continuously, and that will make you a better detector and and also allows you to better characterize the lesions in the future. Thank you for your attention.
Thank you so much, Raf. Awesome. And please let's show this as well, because ESJ Days 2022 are approaching as well. So thank you so much. Excellent lecture. And so happy to learn that even experts are now becoming able to characterize lesions in IBD. So is it only for experts, Raf, or even non-experts? Do you also see in the future that maybe non-experts in endoscopic imaging might be able to identify those lesions?
Absolutely. I think it's really something we have to be familiar with. Because I mean, I remember entering a room, somebody who started this, and they proudly presented me large patches that they resected because it was a type 3L pit pattern, but it turned out to be just regenerative tissue. So we need to do that. On the other hand, if we are called upon by trainees to look at all these pseudopolyps, they don't realize that that is not where the harm or the danger is for that patient. So they have to look in between the pseudopolyps. So I think we need to do this, and it must be automatically. And it's not so difficult to learn. We all learned it, and it's a technique you can learn like any else. It just needs a little bit of commitment. And I think coming back to what Ed said about the chromo and the virtual chromo, the classical chromo really draws your attention. I think it's better to learn the pit patterns that you then subsequently can translate to virtual chromo endoscopy. So I think you need to go through that. I think everybody who's in this panel now went through that learning phase where we started off with the blue, and then we ended up with virtual, knowing what we had to look for and what the bits would look like with, for instance, virtual chromo endoscopy like BLI, NBI, or iScan, and so on.
Thank you so much, Raf. And I have to apologize that we are a little bit extending, but I hope you like it as well. And this is always with virtual meetings, so we do not have to change the room. And I also see already someone who's asking a question. So let me have a look. I think this is Professor Despott. Ed, what is your question, please?
Yes, Raf, as always, fantastic talk. Thank you. And Marietta too. I really enjoyed it, and I learned. You're both enthusiastic and great teachers as well as the experts. So question, Raf, that Paris O2A plus or minus 2C in the center, tubular adenoma, low-grade dysplasia, do you really believe that was colitis associated? Does it matter? You know the answer, but does it matter? Should we be sort of less involved with those and looking for the crazy, funny ones more? Tell me.
I think the lesion
practice,
the lesion I showed you with NBI definitely, I mean, looked a bit dodgy. So you need to resect it, just like you would do it as another sporadic adenoma. It was a basic sporadic adenoma. I think in the end, it doesn't really matter, but these are the type of lesions we should look for. And obviously, it becomes more challenging when you have a lot of pseudopolyps or still, this wee bit of inflammation that continues to be there. And these are the challenging cases. So my advice is really, I mean, if you find tiny spots, which you can even cold snare, or something that is really different from all the rest, take it out if it's tiny. But if it's bigger, then try to delineate it. And if you're in doubt, always take a biopsy. Even if you take a biopsy of something which is type 2 and you don't trust it, or you can't really pinpoint the pit pattern, just take a biopsy. And that's also how you learn for the next time you run into a similar lesion. So, but I think in the end, we need to resect neoplastic lesions, whether they're sporadic adenomas or colitis associated lesions. And for the management of the patient, it doesn't really change that much. And so we discuss this, like you said, in multidisciplinary teams. Depends on age, multifocality, and especially the close follow-up, I think, is even the most important part after a successful resection to safely manage the patient.
Thank you, Raf. And we have already a lot of questions now, and two very exciting questions from Dr. Oliveira. Thank you so much. And asking, first of all, do you feel also that underwater technologies, immersion or exchange technologies might better help us to identify lesions and maybe even for characterization? And then one of the most challenging questions, what are we doing when we spray, when we're using traditional chromoendoscopy, and then we detect those 10, 20, 30 lesions in the right colon. And before we have learned every lesion in IBD should be really taken out, but we know most of them are hyperplasia. So what are we doing in those challenging cases? Just forgot what we have detected. Very careful characterization and only take targeted biopsies. Should we describe this in our endoscopy report as well, that we have seen so many? So what is your answer to this most challenging question, please?
Yeah, there is no data on the water, but actually the most beautiful images you can get is with the classical blue dye, and then underwater. It's really amazing. It's like the coral reef in Australia, what you're looking at. So you can really, I mean, if you have like, even if you have a standard definition endoscope and you don't have access to high definition, it can actually be a very good aid in improving characterization, I think, provided the bowel is clean enough. But it's a natural magnifying way of increasing the visibility, that's the challenging patient. The second one you described, where you have so many polyps, and you do need to have this integrated approach. So you discard all the reassuring pit patterns and anything that is not one or two, and if you have these dilated crypts, then you start biopsying, and sometimes you end up with 10 or 15 targeted biopsies during surveillance. That's what it is, right? Otherwise, you will never detect those. And if it's regenerative, you know it, and then you're reassured. At least you had a good look at everything that was suspicious, and there's no neoplasia. So that's better than just picking the pitch, like Ed was saying, and trying to hope that you will find something that isn't there or not. So that's the advantage. And some of these colonoscopies just take a lot of time if you want to do it properly, but then at least you can reassure the patient that anything that looked suspicious was biopsied, and that the pathology is reassuring. That's how we do it.
Thank you, Raf. And you're not only expert in imaging, but also on advanced therapeutic techniques. So you're also very good and great in ESD, and you have a fantastic ESD workshop in Leuven as well. I was so happy to join you a couple of weeks there as well. We have a specific
question
for this. It's yielding in fibrosis, and that you have also shown us fibrosis. Of course, it's challenging, but it's not that much problematic. I always say one biopsy is not making such a big fibrosis that we cannot resect the lesion at all. But what is your opinion on this? And he's also asking, so always a second pathologist for dysplasia, at least for indefinite for dysplasia or low-grade dysplasia. What is your recommendation on this, please?
Do you take this one?
So biopsies for all the lesions, and always a second pathologist for really to be absolutely sure if a lesion is high grade or low grade or indefinite for dysplasia.
I would say 2 times yes, to be sure. Yeah,
absolutely. I was also saying, and Ed, you have shown us in your most impressive video, fibrosis is challenging, but for the expert, it's not the problem at all. So of course you can take the biopsy, and afterwards one can even remove a lesion. Maybe you should not take extensive biopsies. Yeah, so maybe not 10, but even if you're taking 2 or 3, this is not interrupting the whole endoscopy procedure. No, thank you so much. And again, sorry that we're a little bit extending, but I hope you enjoyed as much as we do. And I enjoy so much even introducing our next colleague and good friend, Dr. Eugenio Tontini from most beautiful Italy. And to learn from you about small bowel endoscopy and Crohn's disease, because you'll see what's going on in this field. And I feel now we're talking about traditional endoscopy, but when we'll do the same webinar in 3 years, a lot of things will have changed in endoscopy, and a lot of things will have moved to capsular endoscopy, in my opinion. And therefore, Dr. Tontini, Eugenio, we're so much looking forward to your talk. Thank you so much for your time. And again, we see that you're still dressed, so you're still in the hospital. So again, thank you so much with your busy schedule.
Grazie, Helmut. And thank you, World Endoscopy Organization, for this, honorable invitation. We will speak about deep small bowel endoscopy. Therefore, we will speak frequently about capsule endoscopy. At present, several devices for small bowel capsule endoscopy are available. For many hospitals, they are comparable, but most of them has a single camera and a discrete image definition. Here you can see 3 different devices with standard view, double-headed view, and with panoramic lateral view. On the contrary, when speaking about flexible enteroscopy, We will use probably device-assisted enteroscopy, like double balloon, single balloon, spiral, or through the scope balloon enteroscopy. All these flexible enteroscopy tools can adopt all the advanced endoscopic imaging technologies already developed for the upper and lower GI, including virtual chromendoscopy, full HD definition, endomicroscopy, and many others. Flexible enteroscopy is obviously much more invasive than capsule endoscopy and small bowel radiologic imaging, but it allows interventions such as biopsy, tattooing, capsule retrieval, and endoscopic therapy. In IBD, in the setting of IBD patient, small bowel endoscopy is a growing field both for clinical and research purposes. And in fact, based on this very recent survey from Europe, up to about 20% of small bowel capsule endoscopy performed in the last years were performed for suspected or established Crohn disease patients. And this growth in IBD deep endoscopy needs probably reflects several aspects. First, small bowel endoscopy has the highest sensitivity for mucosal lesion in non-stricturing and non-penetrating Crohn disease patient as compared to other techniques like radiology, for example. 2/3 of Crohn disease patient has deep small bowel lesion, which cannot be identified by standard endoscopy. And consistently during the last 10 years, both clinical and endoscopic guidelines such as ECO, ESG have enhanced the indication of this small bowel endoscopy in patients with suspected Crohn disease. The same guideline have also upgraded during the years the role of small bowel endoscopy in patients already diagnosed with Crohn's. Example for staging in patient with a new diagnosis, or even in patient with an established diagnosis whose symptoms are not completely explained by the last lower GI findings. Finally, there is also emerging evidence, honestly not yet supported by international guidelines, which promotes the role of small bowel mucosal healing as a key treatment goal in modern strategies. In fact, there are several studies and systematic reviews that, according to which capsule endoscopy is not only safe and acceptable, not only for the patient, but also for the clinician, but it is also accurate for monitoring small bowel Crohn disease and to predict the future disease course, much better than using only radiology or only fecal calprotectin. Emerging strategies are also under discussion. One of the most voted is the use of double head endoscopic view to perform a planetary capsule. This has been used in the last year to perform a complete single-sitting exploration of both small bowel and colon in different clinical conditions, including not only Crohn's, but also melena with negative upper GI endoscopy or familiar polyposis. In the setting of Crohn disease patient, planetary capsule can be used to monitor the midgut disease and predict the findings at colonoscopy with high accuracy when compared to colonoscopy. And moreover, there is also initial evidence suggesting that double heads view can see more lesion in the small bowel as compared to single view, thereby improving the diagnostic accuracy in the management of patients with Crohn disease. Finally, sometimes we ask to ourselves, and the patient asks to us, is capsule endoscopy safe in this setting? Indeed, I believe that this is at least in part up to the gastroenterologist, that therefore up to us, because when adopted in complicated resected Crohn disease subject, capsule is retained in about 10% of cases. But on the contrary, when selecting properly the patient with valuable patency test, we can reduce the retention rate to that of non-IBD subjects, therefore in between 2 and 3%. The only cons of patency testing is represented by false negativity, which could preclude a safe administration of capsule in about 10 to 15% of the patient. For this reason, most centers avoid the use of patency testing in those patients with suspected Crohn disease without any obstructive symptoms or personal risk factor for retention. And other centers also are used to schedule a small bowel imaging test like a plain X-ray the day after the patency capsule administration to look for the capsule over the small bowel. and thereby confirming an high rate of patency test. Which kind of weapon are allowed for endoscopic therapy in small bowel Crohn disease patients? Device-assisted enteroscopy is the reference standard for capsule retrieval, stricter dilation, and much more rarely to detect and treat small bowel bleeding occurring in a patient with Crohn disease. When endotherapy is needed, mainly for balloon dilation, ESG recommends a meticulous assessment of the small bowel anatomy to avoid intervention in multiple or angulated or ulcerated or lung strictures. And this can be made using standard through the scope disposable balloon catheters up to 15 millimeters as shown in this video. Alternatively, but not only, only in selected cases, endoscopic striaturotomy can be performed using a precut or ESD needs, as reported by some referral centers in US, then in China and in some referral center also in Europe in the last years. By the way, a technological revolution that will radically change the world of enteroscopy is already underway, because according to the intrinsic nature of capsule endoscopy, artificial intelligence is perfectly suitable to this kind of diagnostic tool. In fact, based on recent systematic reviews conducted in the field of capsule endoscopy, according to initial pilot study in the setting of IBD patient, there are to date several artificial intelligence-driven softwares that can already detect and classify small bowel lesion associated with Crohn disease with high accuracy and even better than expert humans, but still working on fixed images. When these data will be confirmed in a phase 2 kind of studies on full-length video in a very near future, probably a semi-automatic capsule reading system will become the new standard for detection, characterization, and localization, resulting in an improved diagnostic accuracy and a reproducibility, shortening the reading time and facilitating our real life in capsule endoscopy in IBD patients. Thank you. This was the last slides.
Yeah, awesome. Thank you so much. And specifically what we have learned from you, at least, so about the potential of artificial intelligence in small bowel endoscopy, because I remember from the old times, it took so much time to evaluate those images. Then with the new rapid viewers, it goes very smooth and fast. But of course, the future is artificial intelligence, and specifically, again, I'm absolutely convinced that in the future, we'll learn so much on the application and possibility of capsule endoscopy. So when is your recommendation to do really endoscopy-based, so device-assisted enteroscopy in IBD patients? So would you always recommend to swallow the capsule or only in specific circumstances? And when there is a small lesion present, would you go there with device-assisted enteroscopy, whatever you have in your department? We are preferring, of course, double balloon enteroscopy. But what is your recommendation, please, on this?
When the suspect of Crohn disease in a patient with a suspected diagnosis of Crohn disease is very high, you identify very clear lesion, very suggestive for Crohn disease. From the optimum will be to achieve the histologic diagnosis, and so to perform double balloon enteroscopy, to perform biopsy. But of course, in an initial stage, you can even accept the clinical diagnosis, avoiding the double balloon enteroscopy if the double balloon enteroscopy is not immediately available in your centers, and if the lesions are not so superficial, so are in the very deep part of the small bowel. But mostly, you should confirm the diagnosis using device-assisted enteroscopy and the histology, of course. In a different scenario, when the patient has an established diagnosis of terminal ileum Crohn disease or large bowel Crohn disease, is not necessary to confirm the diagnosis with histology, performing double balloon enteroscopy if you find a clear lesion which is associated with Crohn disease at capsule.
Okay, thank you so much. And there is also, John, some new data on panintestinal capture endoscopy in Crohn's. Would you see a real potential for this device? So evaluating the stomach, the small bowel, and the colon just with one swallow of a good piece of water?
I'm a fan of that, but we still need to measure the cost effectiveness of this tool, comparing this tool to the standard step up tools, because we know that when comparing capsule, panenteric capsule to ileocolonoscopy, the accuracy is very high. But on the other way, I'm not sure that in most cases we can avoid colonoscopy for our patients. So we need to select the proper setting where capsule panenteric endoscopy can replace ileocolonoscopy, adding some additional information for the small bowel. Maybe patient with a clear history of Crohn disease without any needs to check for disease activity in the large bowel, without any need to surveil the large bowel. Maybe patient who have received the colonoscopy some months before, and we just need to go in deep in the small bowel, but we still need to design the proper setting when using this device. But I'm sure that in the future we will find some situation in which we will able to avoid colonoscopy, thereby performing only panenteric capsule endoscopy.
Thank you so much. And before I'm asking my good friends and faculty members, everyone to provide a very short remark by herself and himself, I also want to ask the question, do we also always mark suspicious lesions, so by endoscopic tattooing? Of course, in order to find them afterwards, of course, when you have a suspicious lesion and you're taking a biopsies because you are afraid that this might harbor some dysplasia, of course, endoscopic tattooing is always a good choice. Otherwise, especially in chronic IBD, where you have a lot of fibrotic lesions, it's extremely awkward otherwise to find the small piece. And of course, endoscopic resection nowadays is possible. And we want to avoid pancolectomy in those patients, of course, as well. And then, Marietta, maybe you can give the first closing remark and also answer maybe the question of Dr. Datta from India. And so happy that we have so many participants from all parts of the world today. So should we also take biopsies from the entire colon in IBD nowadays, or is it not worth anymore?
If we are at early diagnosis, definitely we need to take biopsies from the terminal ileum and for each segment, so right, transverse, left, and rectum. And if the diagnosis is well established, of course, will depend of the activity of the disease. And then it will depend if we are talking about ulcerative colitis or Crohn disease. And it depends also what is your goal in terms if you, let's say you have an activity of the disease, and I personally, I still take biopsies. So in my practice and also in the echo practice, we take biopsies also when the diagnosis has been made and to reassess again the disease. Of course, we will just reduce the number of biopsies, but we're still doing.
Thank you so much, Marietta. Do you want to give us some closing remarks from yourself? So what was your impression of today's webinar from the WEO?
I think it was a great webinar with great speakers, and definitely I think there are important tips and tricks to take home. And from my perspective as a healing, I think I will recommend people just to use all their the best toys they have in the unit, because I think this will help definitely to improve quality in IBD endoscopy, which is crucial for delivering good care for our patients.
Thank you so much. So Ed, for your side.
Thank you. And thank you for A lovely talk, Gian. Helmut, I'm going to take poetic license or scientific license here. I'm going to say a couple of things on my thing, but then I'm going to jump on Gian's wagon. So number one, for the dysplasia detection, wash, have a clean colon, the cleanest colon you can get, all right? Take it to the laundrette, wash it, and have your highest definition scope. Those are the three main things, okay? You can play with dyes, you can play with e-chromo, but have the best scope, high definition, and have a clean colon, and take your time. Jumping onto John's wagon. So, as you know, we have the busiest double balloon service, I think, in the world after GC Medical University. We do up to 9 double balloons a week. So the bottom line is double balloon is king and here to stay. There are other things such as power spiral. It's not been tried and tested in strictures. Be careful, it can get stuck in the esophagus, it can get stuck anywhere else. So be very careful. All right, not all double device-assisted enteroscopy is the same. That's number one. Number two, choose your strictures properly and dilate them. You can get very good outcomes and you can save patients' operations. A lot of operations you can save and you can repeat it. Number three, you can fish those capsules out for sure. And number four, in terms of biopsies, many a time you do not need biopsies, but if you are in doubt as to whether this is a lymphoma and you want to start infliximab or something funny, and you're not sure and you need to roll out TB, that's where the biopsies head. The biopsies will not tell you this is Crohn's. The biopsies will tell you this is not TB, this is not lymphoma. All right, so that's bottom line from me. Thank you.
Thank you so much. Yeah, so John, Edward was so much referring to you. So please give us your closing remarks.
You're on mute.
Yeah, you're still unmuted, John. You have to unmute your phone.
I'm sorry.
You're not
Thanks, first of all, all of you for your comments. I noticed that we spoke frequently about training. I think that training was one of the main terms used in this webinar. Not from my side, not so much, but I think that society like ESG and WEO are fundamental, are crucial, because with the training we can improve our average level, and webinar like this are focused on this, and I think that training will be one also of the most important aspect that we should expand in the next year, because okay, we have artificial intelligence, and artificial intelligence probably will make a great part of our work in the next years, but without our ability to distinguish in between different topic and different scenario, artificial intelligence cannot do our work alone. So training is still fundamental.
Thank you so much. Very important, maybe even for future webinars. And finally, Raf, can you please give us your final remarks?
Yes, thank you, Helmut. I want to thank you first for inviting me to this really excellent webinar. I think we covered all of the aspects that has to do with endoscopy and IBD, the basics, and also the future aspects that are coming, that are looking around the corner. But there's still a lot of work to be done. And since this is a worldwide endoscopy forum, I really would like to emphasize and echo the basics that Ed also put forward. So one of the reasons why we introduced the training that Gian was referring to is that there's no longer an excuse not to apply advanced imaging in your daily practice, right? It is so simple. This entire group of experts, as they sometimes call it, we all learned it ourselves, right? So anybody can learn it. It's just a matter of starting it. And now I think there's some guidance on how you can safely do this from a medical legal perspective, I think. So this is a consensus that was made by people who went through these learning curves. So now it's really time to start implementing it. Use your best endoscope, but even if it's a standard definition endoscope, I think there's still even more to be gained by using these dye spraying techniques. And we know that people are still working with that. So we have to realize that. So there's still room for the classical dye spray chromendoscopy in those settings. If you are spoiled and you have all the nice latest gear, then you can move on with the high definition, virtual TXI, and whatever you want to call it. So that's what we learn, but we need to cover everything. And I think that's what this WEO meetings are about. So thank you again for inviting me, Helmut. It was a great setup.
Thank you so much, Raf, and the whole team. And maybe at the end, Enke, if you want to show you as well, because we have great help in the past. So thank you so much for WEO in organizing this. Thank you so much for all your time and participating. Please join the WEO website. Mark yourself for the YouTube videos, which are coming very soon as well. Hope to seeing you soon. Take care and stay safe. Thank you so much, and bye-bye.